So one specific question, where can attendees find the depression management tool for primary care doctors that you referenced earlier?
Well, it's available. They can contact the people at ICSI, who ran the Compass program. They can contact NRHI directly, and we can get it to them. I'll be glad to share that document which I developed with them.
Great, and so I'll put a link to that organization and information about that program into the link, and then if you want to follow up with NRHI, you can do that as well. So also to reiterate, because some people have asked, yes, a recording of the presentation and the slides will be available, and a link will be sent to everybody who's attended after the session today. So one other sort of question that, and a comment that came in that you might be able to address. So someone noted earlier that, you know, one of the challenges is if patients see specialists less, that has an impact on their revenue. And a number of people put in the comments when they registered that they were curious about how to help specialists reduce costs. So you alluded to this a little bit, but could you talk a little bit more about some of the thinking along those questions and comments?
Well, I think we do have a perverse reimbursement system, and there are some experiments underway to deal with that. Many of the subspecialists are overwhelmed by too many patients, and would, in terms of the quality of life, would benefit from having a more reasonable patient loads, and wouldn't be damaged by a loss of revenue from that point of view. So I think that reducing the number of patients, and we faced this with the behavioral health integration program, we thought that the psychiatrists would be upset that they had fewer patients, but they were actually very pleased because they were getting to be the psychiatrists they had wanted to be, instead of having to have these 15-minute med checks, which were wasting everybody's time. So I think that's the case with all the subspecialists that have too many patients. They'd rather see them get good care and not need their services and concentrate on the more complex cases. But we do need to have a way to pay subspecialists to take care of primary care practices. The idea of an endocrinologist that could serve 10 primary care practices and help them take better care of their patients so they don't need intensive and expensive care is an exciting one. But we're not yet set up to do that. We're hoping that some of the bundled payment programs could begin to account for this. And there are some experiments and ACOs that are beginning to show benefits with this. So that as an endocrinologist, I would get paid based on the outcomes of the patients that I am in contact with, rather than the number of office visits. That would mean that it would be very much worth my while to hire more diabetic educators, because we know that's going to improve outcomes.
Yeah, you know, you've kind of, you know, referenced this, but another comment shared was that it seems like so much of this care revolves around good communication, and in the absence of total capitated care, there aren't resources necessarily to spend on that approach. Do you have any thoughts about what's preventing systems from taking the risk to fund these sorts of programs and things like that?
Well, there are a number of parts of it. The fact is that the disincentives are very small. And some surgeons have said, I don't want to fool around with that stuff yet, because all I have to do now to deal with that disincentive is a couple more surgeries. But that really isn't what they want. What they really want is to be able to build a system that works well. And I think that it's going to require a bottom-up kind of approach to building these programs rather than a top-down. I would foresee regional hospitals getting together with their specialists and subspecialists and putting together an approach to a certain, like COPD. And we've done that in 6 hospitals in Western Pennsylvania, and we're able to show remarkable reductions in cost and reductions in harm. And actually, the hospital made money on those systems. But bundled payments and capitated care would allow more innovation if it's done properly.
Great. One quick thing, I know the NRHI team has put a survey link into the chat, and they'd very much appreciate your feedback on that survey before you leave today. One other question that came up from a large specialty we are largely specialty based, and in some areas have significant waits for patients to see a specialist. In those cases, they end up with a very high rate of no-shows, which can also lead to increased utilization. Do you have suggestions about dealing with no-show rates in specialty care?
Well, the key there is to build the capability in primary care. If I can take care of it in my office, that's what my patients would want. We had a lot of trouble getting colposcopies done for our patients with abnormal pap tests. But when we were trained, had some people trained in our practice to do them, we went from 44% completion rate to 88% completion rate for colposcopies. So part of that is building capacity in primary care. The other is by having relationships with primary care. It's one thing to say, I think you ought to see a cardiologist, here's a list. It's another thing to be able to say, I want you to see Gene. I've worked with him for years. He has good judgment. He's not overly aggressive. He'll help you understand your disease and get control of it. So rebuilding some of these relationships between primary care and consultants so that patients can get a warm handoff can also be helpful. Finally, understanding what's the reason for the no-show. If it's transportation, you can, in certain cases, we've used cab passes and bus passes to make sure people can get there. There's even a program with some of the Uber and Lyft groups where they'll work with healthcare organizations to make sure people can get transportation. So you need to find out what are the causes and you need to deal with each of them separately. But certainly warm handoffs and transportation are high on the list.